Hi, my name is Margit Anderson, and I had the privilege of working with Sydney Neville on this project. As most of you know, though, she did just have her baby boy, so it will just be me presenting this for you. So we decided to focus on reducing alcohol abuse. So, to start with a little bit of a background, it is a Healthy People 2030 goal. We want to reduce the number of adults engaging in binge drinking, and to do this, we want to figure out why people are choosing to participate in binge drinking, since there are so many negatives with it. Where does it come from? Is it genetics? Do people who grow up watching their parents drink, are they more inclined to drink? So we wanted to figure out why this is happening and how we can better target that audience. So as you can see by this slide, it does have quite a bit of financial loss as well as health problems associated with it. So for the American economy, there is a $28 billion loss in healthcare. Workplace is $179 billion, collisions are $13 billion, and criminal justice is $25 billion. So some of the health problems associated with binge drinking are unintentional injuries, violence such as homicide or suicide, sexually transmitted diseases, unintended pregnancies or poor pregnancy outcomes, including miscarriages and stillbirth, chronic diseases such as high blood pressure, stroke, and it does actually increase your risk for cancer, so breast cancer with females, and then other cancers with the liver, rectum, mouth, pharynx, larynx, and esophagus. And then it also can affect your memory and learning problems. So our PICO question was, would early intervention programs reduce the number of young adults who abuse alcohol? And so to figure this out, we had to find the why. So our topic is to reduce the proportion of young adults who engage in binge drinking of alcoholic beverages during the past 30 days. So our early literature search consisted of the CINAHL Complete and Medline Complete. The key terms that we used were alcohol abuse, early intervention, and binge drinking. The years that we searched right away were 2020 to current, but we did have to go back farther than 2020. So the first quantitative study that I did was the non-experimental quantitative study. And the question was, does parental alcohol abuse cause increased stress in their children? So will it cause them to drink or binge drink later in life? The researchers were not ethically able to intervene. It was not cause probing, but it did show correlation. The design was a prospective design, and this was appropriate for it. It was also cross-sectional, so the data points were collected at one time. These data points were psychological and somatic complaints, ages, perceived stress, low to heavy drinking, family structure, and parental education. Matching was used as the co-founding variable, but there also could be other reasons why the child ranks their stress as high. So we did include social class. I keep saying we. It is the researchers included social class and household cash margin. So these were used as control variables to help us get more accurate results. Temporal ambiguity was also a threat to internal validity, so it was difficult to determine whether the independent variable specifically caused the dependent variable. So were the parents drinking causing the children to report increased amount of stress? So disadvantages included not being able to determine causation, but we did see correlation. The study was done in Sweden, and so is it the same in America? Is it more? Is it less? Attrition was mentioned, so some participants were lost over the course of the study. All of these limitations were acknowledged by the researchers, and so the external validity is also what is considered heavy drinking. So what is the amount considered heavy drinking in Sweden and then other parts of the world? So like I said, this was all mentioned by the researchers, and despite those limitations, we still wanted to do further research. So critique of the data collection. This was a self-report, and it was actually a survey done by the Swedish Level of Living, and so this is already actually done by 0.1% of the population. So this was kind of easy because they just added on the questions to the survey. It was done in person and then just paper questionnaires. Composite scales were used to tie in all of the variables. Sensitivity analysis was used to validate the results, so there were a cutoff for heavy drinking, so not just like 1 or 2 drinks here and there. There was predictive validity, and the research shows further studies would be worthy of our time. Critique of the statistical analysis. Descriptive stats were used, and it was presented in tables. Major variables and characteristics were listed in the previous slides. There were both mean and percentages. Recall bias was mentioned, so remembering how much or how often a person drinks. Sometimes that was hard to remember. No inferential statistics were noticed. Cross tabulations and Chi-2 tests were used, and then a 95% confidence interval was used as well. So after exclusion, 909 adolescents were used in 629 households. So they didn't dive into this, but it would be good to know. Obviously, these had to have been siblings because there were less households than adolescents. So I'd like to see if those children rated their stress, that were siblings, rated their stress levels the same. And so that could help us determine if how much correlation there is. Multivariate procedures were not used. The study was only trying to find the association between the 2 different variables. Besides the descriptive statistics and the Chi-2, there was also logistic regressions, and these were all appropriate. Results that were significant, so the null hypothesis was rejected. It is plausible, and the effects were sizable. There was a potential type 2 error because we didn't include things such as parental illness as a factor, and this could increase stress in children, and so this could give us a false negative result. Reliable measures of control variables which remained constant throughout the experiment, and everything was properly organized and clearly stated. Critique of the study interpretation. So future discussion and research was mentioned, and it is important. So we must gain more knowledge on what alcohol can do to families, not only right now, but in the future as well. We talk about generational sin. Will this impact the generations to come? It mentions using longitudinal surveys to examine long-term effects, and this would be great if we could actually follow these people later on to see if there is an effect on the offsprings. And there was no mention of statistical or clinical significance. So next we'll move into the qualitative study that I found. And I always pronounce this wrong, phenomenology can be inferred. This talks about why college students choose to participate in binge drinking. So we moved up from children to college students, and we used the ages of 18 to 20. This was conducted at a university in the early afternoon. The data sources include focus groups and alcohol use, disorders, and identification tests. So you'll hear me refer to audit quite frequently talking about this study. So it led to in-depth examination, the reasons why these students chose to drink and why they would choose not to. There was no reflexivity. Longitudinal perspective would be an idea after results are found and the intervention is made, and it was from an ideological perspective, and it was transformative. So critique of the qualitative data collections for the first one that I found. The characteristics were male and female separated groups. Like I said, they were ages 18 to 20, and they were undergrads. Male had consumed 5 or more drinks in one sitting, and then female was 4 or more in the last 2 weeks. It was self-reported focus groups, so they couldn't really keep these answers anonymous among each other. There was a topic guide, and they would ask questions. Here's an example. What do you like best and least about drinking? They wanted to make sure that the language wasn't offensive or it didn't condemn alcohol, because it would make sure that these students could give a more honest and rich answer. And since these students were 18 to 20, it's technically illegal for them to be drinking, and the campus that it focused on was actually considered a dry campus. And these interviews were also recorded. So there was a selective method for category scheme, which can be assumed. Researchers were able to pull out statements that were essential to the analysis. These major themes included alcohol experiences, social lubricant, peer influence, and rite of passage. So those were the reasons why the students chose to drink. And then the reasons why they chose not to would be just social consequences. So the themes were conceptualized so that each could be used to better target and market the correct audience. The tables were provided to give examples of questions that were used in both the audit and the focus group, and I'll kind of explain what the audit is in a little bit more detail soon. And so it did paint a clear picture of why students choose to drink or choose not to drink. This could have been both trivial and obvious depending on the reader. So for me, I went to Indiana University at undergrad, and they're actually known for drinking, unfortunately. And so to me, a lot of these answers from the students at this university were obvious, but depending on the reader, it could have been trivial as well. So critique of the qualitative study for the trustworthiness and the integrity. So there were efforts to enhance the quality of it. So like I said, that audit questionnaire was done. And so the participants would actually take this audit. It was a 10-question criterion validation with construct validity, and they had to score at least an 8 out of 18 to be qualified to partake in the group. And so if they scored an 8 or above, that meant that alcohol had a negative effect on their life. This could be applicable to other colleges. There was authenticity, and so we can experience the whys and the why nots by reading the results in the discussion portions. There was no malicious intent, and there was no offensive language used. The limitations of it is it was one school. The participants were also volunteers, and they were self-reported, and so there could be some students that did not volunteer and actually were in denial about their alcohol use, and that's really probably who we want the answers from. But despite these limitations, it was still worth finding the motives behind binge drinking. The future direction for this is, so we want to make sure that we focus on a language that's not offensive, but also catches the eye of the people drinking. And so something that we found, like I said, one of the reasons why they decided not to drink were the social consequences. And so guys didn't want to be the sketchy drunk guy, and girls didn't want to be that girl. And so we want to kind of focus our language on that, because the past efforts only focused on academic and legal repercussions rather than social ones. And so if we form these respectful relationships and we specifically address the students' motivations, that's what's going to help us change that risky behavior. So I'm going to get into Sydney's, and so I'll be reading a little bit more off the slides than I was before, but so I'll dive into hers right now because she did help tell me what to do and what to say. And so the study performed on our quantitative study design of number 2. It was an experimental study using a randomized controlled trial method, and so now we're going to get into prevention of it and treating of it. So the research question was to see if using an interactive voice response, or IVR, would help patients to self-report alcohol abuse and thus open a door to discuss those different treatment options. The control group did not have the pre or post-visit interactive voice response. Data was only collected after the visit with the participants, so it could be considered cross-sectional. The lack of longitudinal data collection could be considered a limitation because we can't assess the changes in the participants' behavior over time. One of the main limitations addressed in the article was having to rely on patients to self-report their experience, which made them subjected to recall and impression management bias. Randomization was also used to help control co-pounding variables. Next, prior to the pre-visit of the IVR patients, they had to screen positive on the single alcohol screening question. So this asks, how many times in the past year have you had 5 drinks for men and 4 drinks for women? So you can kind of see that there was a trend going on here where binge drinking is actually considered 5 or more for men and 4 or more for women. The researchers collected data for the intervention group before their appointment with their primary care provider and again after their appointment. The data was self-reported by patients. I believe this was an appropriate method to collect the data given the research question. No training was mentioned by the data collectors, and the study didn't offer reports on reliability. The only thing it mentioned about validity is that it is limited due to the proxy measures for clinician behavior. There were other studies that were used to help support these findings. So for the statistics portion, descriptive statistics such as the mean, the standard deviation, and the percentages and frequencies were used. There were also tests to assess the threats to the study's validity, such as the attrition and selection bias. Inferential statistics were reported, including hypothesis testing and parameter estimation through confidence intervals. Effect sizes were also reported, and the results were clearly stated in the key results section. There was a risk of recall impression bias from the patients to prevent the occurrence of researchers they attempted to do their post-interview close to the patient's appointments with the primary care provider. The multivariate factors used in the study included age, gender, marital status, education, and more. Some of the significant results indicated that 52% of the intervention group reported having conversations with their primary care provider versus the control group at 44%. So this is showing that this was working, the IVR was working. There was no significant or type 2 errors that were reported. It is stated that it is difficult to determine the validity of the study since the results are solely based on patient recall. The findings were logically organized with tables and clearly used to summarize the statistical information effectively. Critique of the study interpretations on the quantitative study. So the researchers discussed implications for clinical practice, such as the potential benefits of the IVR. However, there was no mention of implementing the intervention into the practice. Specific recommendations for future research might include exploring the long-term effects or comparing the intervention approaches. Statistical significance was provided with the results, but there was no clinical significance proven. If they were able to prove clinical significance, perhaps there would be a plan for further implications in the practice setting. It would be beneficial to further research this topic to help prevent alcohol abuse and the complications that do come with it. So now we will dive into the qualitative study that was found. And so the study conducted aimed to explore factors that facilitate and impede access to the treatment for alcohol dependence in the primary care setting again. So the study used constant comparison, which is used in grounded theories, to analyze data in primary care settings in Northwest England. The research objective is to examine the perceptions of both primary care practitioners and adults with alcohol dependence regarding service provision and to describe help-seeking behaviors for adults with alcohol dependence. So they used a multi-method purposive sampling technique to choose their participants. It did not appear that the study used an emergent design, as nothing changed based on the early data collected. These 3 researchers coded and reviewed the data to prevent reflexivity and enhance the integrity of the study, such as using purposive sampling techniques. A longitudinal study probably would have been more beneficial, but data saturation was achieved during this study. So the characteristics: the participants were eligible to participate in the study if they were 18 years of age, had a current diagnosis of alcohol dependence, and were registered in Liverpool, UK, and had previous or current experience with management, treatment, or referral of adults that suffer from alcohol dependence. So to gather the data, the participants were interviewed one-on-one with a semi-structured method. Interviews were conducted via Teams, telephone, or in-person, depending on the participant's preference. 23 phone interviews were recorded. For the 2 participants who refused to be recorded, interview notes were taken. There were no examples of the questions in the study, and the researchers conducted the interviews but did not take place in the study. So critique of the qualitative study analysis. Researchers used an inductive thematic approach to code data. No specific coding scheme was identified in the material. However, Braun and Clark's 6 steps were utilized, which include familiarizing yourself with the data, generating initial codes, searching for, reviewing, defining, and naming themes, and producing the report. The data was adequately captured and the data saturation was achieved. Some themes were discovered when reviewing the data. One of the major themes that was revealed was that the treatment for the alcohol abuse was reactive instead of preventative in nature, and that is obviously not something we want, but at least we're trying to work on something. Secondly, there was found to be a stigma around alcohol abuse that causes a barrier for treatment. Overall, there was an expressed lack of support for mental health, peer support, follow-up care, and a lack of aftercare for patients when they have completed a treatment plan. Unfortunately, I know plenty of alcoholics that, they are on their journey to becoming alcohol-free, and they go weeks and months without it, and then they relapse. And so, while reviewing the literature, there was no conceptual method provided. The context of the phenomenon, the context of it was a social and emotional state of the participants was clearly described. Liverpool, UK is actually the 3rd highest city to suffer from alcohol dependence. and the third most deprived city in England out of 317 cities. In conclusion, there are clear opportunities to support adults with alcohol dependence in primary care and the need to increase provision for the timely intervention for alcohol-related issues with the PCP. So the evaluation of the qualitative study that we just went over for trustworthiness and integrity, there is concern that the study may lack some of the transferability as it is specific population with only one ethnicity being surveyed. The barriers faced by ethnically diverse groups are not considered, nor is it since it's a different community. Further research would need to include a more diverse population with other communities. This is why there is another study based in Scotland to help strengthen the findings. Investigator triangulation was also used to help enhance the trustworthiness of the study by decreasing bias. The findings seem authentic for their community. Implications for clinical practice include, but are not limited to, providing further training for clinicians, using a person-centered approach to connect with patients, and using a primary care alcohol nurse outreach to help reduce the barriers. These interventions alone could help reduce the number of alcohol-related hospital admissions in Liverpool, as well as combat alcohol dependence. Our reference page, and that is all. Thank you.